Um, Good evening, everybody. Welcome to our usual Wednesday slot. Today it's a combination of the FRCS Mentor Group and OR UK. We are very proud to bring you Mr. Shah Punwar. He's a consultant knee surgeon based in University of Hospital Lewisham in South London. His main areas of expertise are knee and hip replacement surgery, as well as soft tissue sports injuries and soft tissue knee injuries. His particular interest is in partial knee replacements, day case arthroplasty and ACL reconstruction. He's a member of the British Association of Knee Surgery and is committed to medical education. In 2013, he undertook a fellowship year in complex arthroplasty and sports injury training in Perth, Western Australia. And before returning to the UK, had been appointed as a consultant in orthopaedic surgery in Lewisham. We are very pleased with his talk today, which is going to be quite important for the FRCS exam, controversies in ACL reconstruction. Before I introduce Mr. Punwar, I just want to remind everyone that if you have any questions, please do type in the chat and we will ask the questions at the end. Also, people who wish to participate in the Viva, please do let Hani Al-Barasi know. You can send them a message or raise your hand in the chat group. And without further ado, Mr. Punwar, it's a real pleasure to hear your talk today. Thank you very much.
Thank you. Thank you, Swan. Thank you for that introduction. Thank you to ORIC UK and the FRCS Mentor Group. It's a topic close to my heart, but hopefully I didn't bite off too much. So let's get on with it. Controversies in ACL reconstruction. I don't have any disclosures. I currently use Smith & Nephew products. We will have one of the longest history in ACL reconstruction work, and there's images here from various sources, no patient identifiable images. Right, what's my objectives today? What are the main controversies? Graft choices, tunnel placement, mainly on the femoral side, to be honest, fixation choices, the additional procedures you might want to do, and just some small print stuff, timing of surgery and rehabilitation. So bone, patellar tendon, bone. Traditionally, this was the go-to graft, easy to harness, front of the knee. Is it still the gold standard? Hamstrings certainly were popular during my training, and low donor site morbidity. And I would say 90% of the ACL reconstructions you'll see will be hamstrings. Quads tendon plus or minus patellar bone block is fairly new, and the Americans seem to be very keen on it. There are minimal grafting, donor harvesting techniques, but time, I think, will tell whether this is a superior graft. Other smaller options are allograft, so donated cadaveric tendon tends to be irradiated and slightly weaker than your own tendons, or synthetic graft, which was very popular in Australia in the 90s, such as LARS. And there's certainly been a move away from that. So, what are we looking for? We're looking for a strong graft. Now, your native ACL has a load to failure strength around 2,000 newtons. A 10 millimeter bone patellar tendon bone graft has more than that, about 3,000 newtons. You're going to get direct bone-to-bone healing. So that's very strong. 4-strand hamstring graft, about 3,000 to 4,000, depending what you read. And that's slightly more than the actual bone patellar tendon graft itself. Quads tendon, similar, and allografts range from 2,000 to 4,000. But as you can see, we're all in the region of over 2,000. These are very strong. That's not really going to be your initial weakness. This is probably going to be your fixation, particularly when the graft is, bedding in. So BPTB, bone patellar tendon bone, popular for heavy males, but there is an increased risk of anterior knee pain, patellar fracture, patellar tendon contracture, but you get this solid bone-to-bone healing. Your hamstrings need to be at least 7.5 to 8 millimeters. Now, if you've got a short, particularly short female, you have to just be concerned that you might have quite short tendons. There is a risk of saphenous nerve injury, and you can lose the end kick of sprinting. But largely, there's very little donor mobility from taking hamstrings. Allograft, so donated tendon, sort of thing Michael Owen had back in the day, really for professional straight line athletes only. So sprinters or rowers. There's a higher re-rupture rate, but it might be just right to get those people through their careers. In some studies, a 4 times higher re-rupture rate. I haven't really talked about return to sport at the level that people were at, but it's something you should consent people for, because I think it is quite difficult for professional athletes to get back to the same level of sport that they were at. The synthetic grafts will eventually fail. They can cause synovitis and bone cysts. It was very popular in Australia following an Aussie football rules player who had a Lars graft and got back to playing very quickly. But since then, there have been lots of failures, and there's now a position statement from Australia saying don't use them. So what's the reality? What graft are you going to choose? It's like anything, spacing your training, your fellowship, and perhaps current trends will influence you. Lots of training opportunities now as a consultant to go to soft tissue labs and even abroad when we're allowed to travel, and keep an eye on what's happening. But I do think your training and your fellowship really does affect what you use. You want low donor site mobility. ACLs tend to be day case surgery, so you want to be able to manage pain. And hamstring tendons are very versatile. The quadriceps tendon is relatively new, something I think I'm looking into, and I'm sure those of you, younger knee surgeons coming through will be looking into. And as I said before, your technique and initial fixation is more important than your graft choice. The weak point is tibial fixation. It's a question you might get asked in the FRCS. There's greater shear forces. And again, remember, the metaphyseal bone on the tibia can be weaker, particularly if these patients are deconditioned. Graft preparation. There is some controversy about tensioning, but it makes sense. It's a ligament. It removes creep. If you pull on your graft, you can't pull on a patellar tendon graft, but for hamstrings, useful to tension. The vancomycin swab is not really controversial anymore. In the papers about using that on your graft, it does reduce infection. I use it. It's really easy to do. 1 gram vancomycin in saline, and just soak a swab, prepare your graft on a graft master, and wrap it in there. Your hamstrings, there's lots of different configurations. I've just put a diagram of some of the things you can do if you want to make your graft stronger. The classic is the one over on the right side there, just a quadrupled semi-T and gracilis graft over usually suspensory fixation. There's an interference screw in the tibia. You can triple your semitendinosus, put the gracilis over the top to make a 5-strand graft. You can, if you have 30 centimeters long of both tendons, stitch them both together and triple them to make a 6-strand graft. Hamstrings should be over 7.5 millimeter diameter, really 8 millimeters. And I'm looking for 10 centimeters long, really, for a standard suspensory fixation on the femur and a tibial interference screw. So that's going to be about 4 centimeters in the femur, about 1.5 to 2 centimeters within the joint, and about 4.5 centimeters on the tibia. And you can adjust your tunnel drilling if you have a slightly shorter graft. You need a shorter graft if you're using suspensory fixation on both sides. It's becoming more popular, such as the Arthrex graft link, but doesn't come without its own possible complications. So femoral tunnel placement, probably the most highly debated thing in ACL reconstruction. You need to know your terminology. It may something that might come up in the exam. Instead of proximal, distal, anterior, posterior, we tend to use high, low, deep, and shallow. Deep being posterior, shallow being anterior. Remember, the knee will be flexed usually at 90 degrees when you're doing your femoral tunnel, and then high for proximal and low for distal. Now, the initial ACL reconstructions were open. I'm not going to talk about those. They violated the fat pad and, much more painful procedures. I think I saw one my first registrar job back in 2007. The transtibial technique is also not used that often these days, though still in quite widespread use, where you would bend the knee to 90, drill through the tibia, use an over-the-top guide to put through the tibia, hook over the back of the femoral notch, and then you can drill your femoral tunnel. Now, clearly, you'll be constrained by where you've put your tibial tunnel, so you tend to get quite a high, graft, really, high and vertical, and that doesn't really give you very good rotatory control. It might give you some AP control, but didn't give you very good rotatory control. So if you look at the diagram on the right, anteromedial drilling, which I'm sure most of you have seen, gives you a greater obliquity, but you do need to hyperflex the knee. Otherwise, you can get shorter tunnels. There's also the risk of iatrogenic damage to the medial femoral condyle, particularly if you're drilling a large graft. But the greater obliquity leads to greater rotatory control. So what's the evolution of femoral tunnel placement? Now, most of you will have heard of the clock face method. Say for a right knee, you could use 11 p.m., quite the old-fashioned high position, and you could use 1 p.m. for left knee. Now, the disadvantage of the clock face is that that's a 2D description, and obviously it's 3D, the notch. So it doesn't give you any idea about depth, but it's still useful as a aim. And I think with femoral tunnel placement, you want to use lots of different things. The ridges are quite commonly used now. There's the lateral intercondylar ridge, so-called residence ridge, because you don't want to go above it. And with the bifurcate ridge, which is meant to separate the two bundles. I haven't discussed ACL anatomy. I'm sure most of you are aware of ample, anteromedial bundle, and posterolateral bundle. And we'll actually perhaps challenge that classic description of ACL anatomy in a bit. So from the clock face, we went down to anatomic reconstruction. Now, if you're doing anatomic reconstruction, you can either do a double bundle, true anatomic, so try and do an anteromedial bundle at the back, posterolateral at the front, or you can do a single bundle anatomic at the midpoint of the femoral footprint, and I'll show some diagrams later, or you can perhaps go to more higher and deeper position at the back of the knee in the center of the anteromedial bundle. Now, we've gone from the higher initial grafts, quite vertical, going more and more anatomic, and I think there is now a trend to go back to a slightly higher and deeper position. So instead of 11 p.m., sort of 10:30 on the right, about 1:30 on the left. And we'll explain why that might make biomechanical and anatomical sense. The ridge technique, the image on the right is from one of my cases. You can see you've got an empty lateral wall. So you've got a PCL on the side here. We don't tend to do notch plasties so much in the UK. I think if you do have a very narrow V-shaped notch, maybe in a lady, and you're going to get impingement against either the side of the notch or the PCL, you might want to consider some form of notch plasty. But you can often see these ridges, and you can see the remnants of the femoral insertion. So I always look for a lateral intercondylar ridge, and then you can look for the bifurcate ridge. Often the remnants will help you decide where these are. If you're going to do anatomic placement, you want to go in the midpoint of the femoral footprint, which is quite low, I think. So there are different ways of doing it. You can measure with an arthroscopic ruler, and often you have to change portals for that because you need to measure on the lateral side, and then you can go in the midpoint of your measurement. So you can measure and go in the midpoint. You could also use the bundles. If you can see the bifurcate ridge, you could just make a mark there. And this is a double bundle technique, but for single bundle, center of the footprint. Double bundle was popularized by Freddie Fu in America, but I think it really has fallen out of favor. If you've got inadequate graft size, you're going to get graft impingement, tunnel placement problems, and at revision, you're dealing with 4 tunnels. So I think anatomic reconstruction is still definitely a thing, but I think people will tend to go more for a center footprint on the bifurcate ridge with a single bundle, rather than go for a double bundle technique. There are other ways of working out where your femoral tunnel is that I don't use. There are grids. There's a Bernhard and Hertel grid. You can use intraoperative fluoroscopy. I think you can always use navigation. And these are ways that you can look at your tunnel placement following surgery, perhaps on a CT scan. I don't use fluoroscopy, but you can take true lateral x-rays. We use it for other knee surgery, such as MPFL reconstruction. And you can use standard percentages that I'll show you later to work out exactly where you want to go. So the anatomy of the knee has been revisited several times. This classical teaching of anteromedial and posterolateral bundles has been challenged. There's a recent concept of the ACL being more flat and ribbon-like, tends to be coming from this paper by Smigulewski from Poland, but working with a very well-known London knee surgeon, Andrew Williams. The recent concept is that it's more flat and ribbon-like. And there are 2 different types of fiber attachment. Direct fibers, which appear to be carrying more load, both histologically and I think macroscopically, and they're attached high and deep within the region of the anteromedial bundle, and then indirect fibers, which have a weaker attachment and take less of a load. This is the paper. It's freely available on the internet, and I'd recommend you have a look at it. So this is also in the paper. This is the posterior femoral cortex. This is the back of the notch. This red line is the direct fibers, which seem to have a double tide mark has been described, seem to have a very strong attachment to the back of the knee. And look how far back it is. You really want to go as far back as you dare. And this yellow one is indirect fibers in the region of the posterolateral bundle, the so-called posterolateral bundle, not quite as distinct. So they propose that we should put our ACLs in the region of the direct fiber insertion. Now, this agrees with another concept from Stephen Howe, Pearl, and McAllister called the ideal femoral location. And this is actually on the Zimmer Biomet website, though it's come from lots of different research, but it's a lovely, lovely bit on the website, and it even gets you to choose where you'd put your own tunnel. So ideal stands for isometric. We want the length tension relationship similar to native ACL. We want it really to stay the same length throughout a range of motion as best as possible. The D stands for direct fibers, as we discussed before. Eccentric means it doesn't have to be in the center of the footprint. They're saying go higher in the footprint and in the anteromedial portion, which agrees with that Smigulewski paper, and they're completely separate concepts from different parts of the world. Equidistant, so halfway to the top and bottom of the notch, which is a good intraoperative check. And in real life, you're going to be using your experience in intraoperative checks. So I clear the notch at the back, and I do look for the top and the bottom of the notch. I look for articular cartilage, and it does tend to be in the middle. Because remember, if you're drilling, say, an 8mm graft tunnel, by the time you've marked your tunnel, it's going to be 4mm bigger forward and 4mm bigger backwards. So you have to take that into account. The A stands for anatomic, and the L stands for low tension. The anatomic, I think, stands for, in the anteromedial bundle, they're not going for a central footprint position. And this is a diagram, which is on that website, and the green part there sort of shows the confluence of where they think all these things coincide. So it's where all these circles overlap in this sort of position, which I hope you'll agree is high and deep in the region of the direct fiber insertion. So where do I put it? I put it in the center of the anteromedial tunnel, so behind the bifurcate ridge, just slightly, knowing that by the time I've drilled, it'll be, say I'm drilling an 8mm tunnel most commonly, it'll be 4mm behind and 4mm in front, but always behind the bifurcate ridge and just under the lateral intercondylar ridge. Now, Clatworthy et al., also with Andy Williams and the Danish registry, has shown a higher failure rate of 3.5 times in the Clatworthy study using an anatomic tunnel placement. That's more of a low, more shallow placement. So, you know, I would go for the anteromedial bundle and I would leave at least 2mm posterior wall. Because if you're going to the back, there is a risk of blowout. That's not always a bad thing if you're using suspensory fixation, but you need to know that you've done it. So I'll show you an arthroscopic picture later, and I always check the posterior walls intact. So femoral tunnel drilling technique is also controversial. We talked about transtibial. I don't think many of you will be doing that anymore. You tend to view from, or I tend to view mainly from the lateral portal. I'm ready to view from an anteromedial portal if I can't get around the corner and I can't get a good view. And if you are viewing from an anteromedial portal, you drill from an accessory anteromedial portal. Most tunnels are drilled inside out, but outside in came in mainly through Arthrex. There's the flip cutter, which you make a hole laterally on the femur, you put in the flip cutter device, and then you can drill from the lateral femoral cortex inwards, open the little flip cutter, and then drill your socket backwards that way. So you're gonna get a socket rather than a tunnel. If you do that on both sides, you can sometimes have graft socket mismatch, as you can have patellar tendon socket mismatch. And so sometimes people just drill an outside in tunnel on the femur and a whole transtibial tunnel from outside in as normal, because you don't want to have more problems. But it is an attractive technique, the graft link Arthrex technique. Flexible versus rigid reamers. I think there's a lot to be said for flexible reamers. You can probably get less of an oblique tunnel and you can get around the medial femoral condyle, but there are many in use. Stryker have them, and certainly I haven't used any as of yet. Just beware your short tunnels anteromedial drilling. There's 3 stages to a straightforward endo button drill. First, it's a 2.5mm beef pin. If you can measure off that and if it doesn't feel right, you can readjust. By the time you drill the 4.5mm endo button drill, you get a good measurement. It can be difficult to change because you get tunnel convergence. You can still change at that stage, but once you've drilled the big acorn reamer, then it is quite difficult to change. So need to hyperflex. Be careful where your hand is. I tend to go about 30 degrees from the midline out to the side when I'm drilling through the anteromedial portal, and I dip my hand slightly. And once you do quite a few, you know where your pin should come out, and you're looking for a tunnel about 40 to 45mm. It's quite consistent if you've got it right. So these are the different views you can get. This one in the middle is viewing from a standard lateral portal. You can get a slightly better view than that. But if you say you've got a view like this and you weren't quite happy that you could see properly the back of the notch, you could change to a high anteromedial portal, and then you could drill through an accessory anteromedial portal and you get more face on. I tend to put my accessory anteromedial portal a little bit more in to avoid the medial femoral condyle. And depending where you put your hand, you can change the obliquity of the tunnel. Some people like very short tunnels. Obviously, if you've got a short graft or you're using a quadruple semi-T, you might want to purposely drill short tunnels. The tibial tunnel is less controversial, really. I tend to use anatomical landmarks, the posterior border of the anterior horn of the lateral meniscus. So that's the anterior horn of the lateral meniscus. You'll all have done knee replacements. You can see that the ACL starts very anteriorly. You want to go in the middle, really. If you go to anterior, it'll be tight inflection. So I find the posterior border of the anterior horn tends to be slightly red. It's obviously seen. And then you triangulate with the PCL at the back and the medial tibial spine. There's also intercondylar eminence in front of the PCL. And you use a 55-degree tip or elbow aimer. I tend to prefer a tip aimer so that I know exactly where the wire is going to come out. If you increase your angle, you get a slightly longer tunnel. And conversely, if you decrease your angle, you get a shorter tunnel, which might be useful. Again, that paper, which talks about the ribbon attachment, there's some nice anatomical specimens showing that the tibial attachment is more C-shaped than two discrete bundles. They actually say the bundle theory might be more of an illusion as the ribbon wraps around itself. And if you look closely where the posterolateral bundle is meant to be on the tibia, it's actually in the area of the anterior root attachment of the lateral meniscus. So, you know, I'm not, you know, I do think there might be a sea change in ACL anatomy. Certainly this is not what I was taught when I finished training, but you can find lots of things about this in the literature now. This is just a picture from a recent case, how I actually do it. You clear the notch, use a shaver, get to the back, a 45-degree awl. It's quite useful because you can hook the back of the notch and then you can just come forward. You know it's 5 millimeters from the tip of the awl to that black mark. So I can measure that to be at least 5 millimeters to the back. And then I put it in using the clock face and the ridges and where the anteromedial bundle I think was before. And you can see I make sure I've got a posterior wall. So clear all the swarf with your shaver and make sure you've got a posterior wall. And you can actually look up your tunnel. For the tibial tunnel, this is actually anterior horn lateral meniscus. It's quite red. And then you drill and pass your graft, check there's no impingement in extension. So you straighten up the graft, and that's sort of a standard pictures I expect to see. How do you evaluate your tunnel placement? Should get some imaging following surgery, ideally before the patient leaves, or at least the next clinic appointment. Plain X-rays are fine. My colleague prefers to do CTs, and that is very accurate. And there is a CT protocol within our trust where you can closely monitor your tunnel placement and adjust your practice. And you could use those grids as before. You can't really do a talk on ACLs without mentioning Leo Pinzeski and the Sydney experience. And I often refer back to this poster because it tells you what you should be looking for on a plain postoperative X-ray of an ACL reconstruction. And the center of your femoral tunnel should really be as far back as possible, so about 86% along Blumenstadt's line, and the tibial tunnel should be no more than 50% along the lateral tibial plateau. But I find that a quite useful way of assessing the postoperative results, tunnel placement, but you do need good quality X-rays, particularly the lateral. And in this paper and study, they found a higher failure rate, so 17% compared to 7%, which was significant if your tibial tunnel was over 50% posterior. So the tibial tunnel placement in the AP plane does appear to be crucial. Fixation. How are you going to fix your graft? There's two main types, interference or cortical suspension. Bone patellar bone grafts, they're usually fixed with screws. Leo Pinzeski, I think, developed the reverse threaded RSI screw, which is a niche thing you might get asked in an exam, used for femoral fixation of the right knee to stop your graft being twisted. You want to ideally put it in front of your bone block. So that's just a niche thing, the reverse threaded RSI screw. Soft tissue grafts, you tend to use quarter suspension on the femur. You can use fixed loops or adjustable loops now. The popular ones are the Arthrex tightrope. There's also the pull-up, and Smith & Nephew also have an adjustable one now. Screw on the tibia, it can be metal, stainless steel, non-absorbable. PEEK, which is not absorbable, but doesn't show up on X-ray, or an absorbable screw. Suspension on both sides is becoming more popular because you can use shorter grafts, but you've got to be careful about the strength of your tibial bone. Some people worry about using tight suspension and buttons on tibias because you can crumple the cortex there, and certainly you can crumple the cortex with a staple. There are reports of tissue reaction in cysts and breakages with bioabsorbable screws, so I don't use those anymore. And with the other screws in the revision scenario, you can remove them. Some people use a secondary fixation, a staple or a screw to prevent shear. You might have non-absorbable whip stitches, well, you will have on the tibial side, and you can tie those around a post. On the tibia, you usually increase the screw diameter by 1 millimeter. Might be something you're asked. The femoral bone tends to be very hard, so if you're using a screw up there, you don't. It tends to be line to line. And you can use a screw in the femur for soft tissue grafts. There are other methods which I haven't mentioned, like the transfix, where you can drill through the femoral lateral cortex and put 2 sort of pins in, and there's a special jig for that, which is popular in the transtibial technique. But though I've seen that used, it's not something I think you might see in very modern practice. Where you fix the graft is a little bit controversial. You should check how high symmetric it is by looking at how far the graft moves up and down tibial tunnel when you go through a range of motion. Tend to fix in 20 degrees of flexion, pushing down in the tibia. If you fix too tight, it'll stretch out. You might limit flexion, but again, you don't want to fix things too loose. There were tensioning devices. Some people use them. They are a bit fiddly, particularly if they want all 4 strands to be separated. So I tend to just pull very hard, or get your assistant to pull very hard. I use an endo button in the femur at present. I have used other fixation methods. The most common one is a 15 millimeter. They still stock everything from 10 millimeters to about 30, probably in your hospitals. It's a fixed loop. It's got the longest track record. The disadvantage is you have to ream a slightly longer socket, your big socket or tunnel, than necessary in order to flip the button. And any of you who've struggled to flip an endo button will know that it's important not to shortchange yourself, and try and be careful when you're pulling those grafts through and protect your fingers. It's quite easy for the wires to cut through into and just cut your fingers. It's a badge of honor. So I use a BioSure screw made of PEEK. It's non-resorbable. It's MRI compatible if I need to scan people again, particularly if I've done a meniscal repair. Occasionally meniscal repairs might be symptomatic. They may fail. You may want an MRI. I usually use about 35 millimeter screw. Tunnel tends to be 40 to 45, and I don't want to go into the joint, but I want to get as much sort of boundary fixation on the tibia as I can. I whip with fiber wire. Others use Ethibond. You could use Vicryl, but I want to protect the graft, particularly from the screw. I just checked time. So it was 8:07 already. So interference screws.
Please continue. It's very good.
Everybody's okay. I'll continue. Interference screws. You've got to be aware of screw divergence. So where you put your guide wire is really important. So I take a little guide wire and I put it into the tibial tunnel, and I like to see it coming out in front of the graft, ideally. If it's in the middle of the graft, then you could damage your graft going in. It could take a little bit of work to make sure you know where that guide wire is. The length is controversial. Some want as long as possible to get aperture fixation, but you don't, especially when you're using metal screws, you don't want to protrude into the joint. So I think 35 millimeters is fine. I don't use screw and sheath types. They're a bit fiddly. You may see it. We've mentioned the reverse thread. You repair meniscal lesions when you see them in ACL reconstructions. Actually, we're getting a lot of people coming through very late, especially with COVID. And, you still have to assess normal meniscal lesions to see whether they are repairable, but that's a different talk. I just want to mention the ramp lesion, which doesn't actually stand for anything. It just stands, I think, like a ramp, but it's a posterior horn meniscocapsular tear, which I have seen. You can hook it. It probably heals by itself in the majority of cases because it's a good healing environment once you've done an ACL. But Bertrand Sonnery-Cotte, another big name, French name in ACLs, he's popularizing posteromedial portals and a little spiral hook to repair properly. You can try and repair them from the front. I've done that, but it's worth trying to get posterior portal in, perhaps in a cadaver first. The lateral tenodesis, that's come back into vogue. The anterolateral ligament been around for a long time. In fact, the early ACL reconstructions were extra-articular, but since 2013 in this class study, it's got a resurgence in interest. And it might explain your second fracture, something that might come up in the exam. Maybe that lateral capsular avulsion is the anterolateral ligament. And in revisions and hyperextenders, marked laxity, very high performance people, you might want to do it at the same time as your ACL reconstruction. You can just take a strip of IT band. There's a Macintosh and Lemaire method. They're quite similar, just different insertion points. I tend to go just posterior and proximal to the lateral femoral condyle, epicondyle. So you take a strip of IT band, feed it on the LCL, back to your tibia. You can fix it with anchors at that point, just posterior to the lateral epicondyle, or a staple. You can get convergence with the ACL tunnel, so you normally go more anterior and proximal with that tunnel. Allen Getgood, they've got some big studies coming out now. They've shown decreased failure rate if you use it with primaries, which stands to reason. It's a greater fixation. You could over-constrain your lateral compartment, so don't pull too hard. You're not meant to pull much on it. Some say the IT band is a main restraint to internal rotation of tibia, so you're going to reduce your pivot shift. So you've got hyperextender, that explosive pivot shift. You might want to do lateral tenodesis. There are other methods. You can use hamstrings as well. There's an elegant method of using a semitendinosus for the ACL and the gracilis for your ALL, but it's fairly straightforward, apart from the capsule can be quite thin underneath the LCL, and you've got to cut the IT band over the LCL. So mark it carefully, make sure you've got a good length, about 12 centimeters you need. You're going to flip it over and then carefully dissect under the LCL, to pass your graft. It'd be good to look at the BAS guidelines now if you're going for the exam, as it's good to look at all the BOA and BAS guidelines. They've got a consensus statement on ACL injuries. There's some controversial areas, such as DVT prophylaxis. Now, I follow my trust protocol. If it's an operation lower limb over 60 minutes of combined anesthetic surgical time, you should consider chemical prophylaxis. So I give a week of Clexane. They say there's no need, there's no risk factors. Interestingly, they say you can perform meniscal repair if you've got an acutely locked knee and it's not ready for an ACL because you haven't got either the expertise or the knee's not quiet, but ideally you perform it at the same time. I recommend you have a look at that. Timing of surgery, generally you wait until the knee's quiet. There's a risk of arthrofibrosis if you start too early, but elite athletes might be ready quicker. They've got game ready, they've got ice baths, they're very motivated. Everybody gets prehabilitation these days. And it's safe to operate as soon as the knee has full active extension and is bending freely to over 90 with minimal swelling. So if you've got someone very motivated, you could operate within 3 weeks. It doesn't happen usually on the NHS, particularly during this COVID time. Rehab. Now, you may well know about open and closed chain. And traditionally, there were 2 phases to ACL rehab. First, graft protection, first 6 weeks, then graft strengthening. Now, it's controversial as to when your grafts are the weakest. Your grafts being neovascularized, they might be the weakest at 6 weeks. So I often think we should slow down around then. But there's lots of protocols now where they're combining open and closed chain. And there are biomechanical studies showing you can have increased forces on the knee with closed chain. So just like, say, Achilles tendon injuries, you've got accelerated rehab. And what remains the same is an initial focus, reducing your fusion, regaining range of motion. 6 weeks, you want to see full extension because it's hard to get that back. Then you work on flexion. I'll allow jogging at 3 months. Return to contact sports is 9 months to a year, particularly football. The tibial slope is beyond the scope of this talk. There's a greater failure rate with higher tibial slope. So in revision cases, you might want to do a slope changing osteotomy. And osteotomy, again, an old technique coming back into vogue, and something you may see a lot of. So we're coming towards the end now. There are some unanswered questions. Which patients do well with your non-op management? You can certainly try non-op in sedentary patients, and that makes sense, unless they've got symptomatic instability. And those over 40 willing to try the approach. I know people have done very well non-op. The risk of OA in the ACL deficient knee has not been proven, yet you would say an unstable joint is more at risk of arthritis, but it's not been proven. And osteoarthritis itself is contraindicated in ACL reconstruction. So I think it's still a controversial area. Some say the initial bone bruising from the pivot shift injury damages the cartilage. And we need more work in that area. So in summary, large variation in practice globally, and even nationally, I suppose. You want a good quality graft, whatever one you choose, secure initial fixation. Your tunnels should allow full range of motion without impingement, avoid excessive graft tension, delay your return to contact sports for 9 to 12 months. Pick a winner. Patients must go through tailored rehab program. It's just as important as the operation. Paper just came out recently out of Nottingham, and they put it on the internet, freely available before press, a systematic review of all standard techniques, and the end result was all standard techniques are comparable. So it doesn't matter what you do as long as done well. And that's it. Thank you very much.
Thank you very much. That was very informative, comprehensive, and broken down into small pieces that everyone, well, I hope everyone who is listening was able to understand. I have got some questions from the audience, if it's okay. So the first one is, do you cycle the knee movement prior to the tibial fixation? And if you do, why?
Yes, you must cycle the knee. And sorry I didn't mention that. I don't think that's controversial, because you put your graft in, you've got good femoral fixation, so you flipped your endo button, great, you're on the home run. You need to now work out how isometric your tunnel is. It tells you how well you drilled your tunnels. So firstly, I will bend it up and down and just see how far my graft withdraws into the tunnel, particularly on flexion, because it's going to be tighter in flexion, okay? And then you want to get rid of more creep. So it's all about getting rid of more creep. There's a viscoelastic material. I actually threw a question at that, one of the MCQs I did, because it's the basic science you might want to do. And that would be a great question in the FRCS, because then you could talk about getting rid of creep and you want to avoid early stretch out. Now, if you don't do it and you fix it all well, that patient may well, stretch out just a few millimeters in the early days, give you a looser graft. We can talk about the basic science of crimp and collagen fibrils. You guys are probably very hot on that.
Okay. So what are the tunnel dimensions when you decide between the single or two-stage ACL revision surgery? Is there a difference?
Yeah, I mean, I just saw a patient with that today, and I was actually just thinking that myself. So when I put a question of that in the MCQs, so perhaps if we're going to do that, we can talk about it. I think it's based on experience as well, and where you think you can get a tunnel in. If you don't think you can get a new tunnel in a good position, near that widened tunnel, it's always safest. It's like a two-stage revision for an infected prosthesis. Your exam answer would be, there's quite a lot of tunnel widening. It's probably safe to do a two-stage. Exact measurements are quite hard to find. If you could measure, if you had some way of measuring on your imaging, and we can talk about which imaging you do, then that would be great, because that would tell you exactly. You might be lucky and you could use that initial tunnel for your secondary revision, if you're lucky. There is some talk about putting in bone dowels and drilling through quickly, but that's a bit risky. But there is talk about it. So I think, really, when it's very small, when you can get past it. It's completely the wrong position. You can stay out of the way. And if it's exactly where you are, best to be safe is probably the exam answer.
Yes. So you didn't mention anything about the primary repair of the ACL.
Yeah, that is controversial, but and actually, that's the bear technique, the BA, the one that they do. They came up in the States with pediatricians. That's something I haven't seen anything of that so much in the UK, where they put a little sponge in between the two ligaments, and they allow the ligament ends to grow into that sponge. I think the sponge disappears. Good for pediatrics. But Gordon Mackay up in Scotland, a knee surgeon, an ex-professional footballer, has popularized the Arthrex, tightrope technique. And I have a friend who's using that technique in Pakistan as well. So it's just like repairing any tendon, like more like a rotator cuff, I would say. People are using suture anchors. So they are using a scorpion. You can simply take the anterior stump. So what would my exam answer be? You need to have the appropriate type of tear. So you want a tear from the femoral attachment. So you want quite a large, you don't really want a mid-substance repair. You want one that's come off the femoral attachment, quite healthy, younger patient. You've got to quite quickly and willing to go through that. There's not really long-term data at present. And then you can simply use, say, a knee scorpion and put strong, high-strength fiber wire through that stump, put it through suture anchors, and tap the suture anchors into the femoral insertion. And I've seen that further stabilize with a tightrope, but there are people who say it's devil's work. So I'd be careful about that.
I wouldn't bring that up in the exam as you would get yourself into a lot of this trouble, because you wouldn't be necessarily being examined by a knee surgeon who might know about these things.
Agree.
Okay, I've got some basic science questions as well. So I've got one about the protocol for weight bearing post-op.
Yeah, I mean, I don't brace my ACLs anymore. I only brace an ACL and restrict weight bearing if I've done a meniscal repair. And you should always restrict root repairs. But I normally full weight bear because you want secure initial fixation. So I'd encourage you to do your EUA before surgery, document, it's part of the BAS consensus, document your pivot shift, your anterior jaw, your lachmans, and the others, and then do it after your fixation. Yeah, when you start off, you might do a gentle lachmans. You don't want to damage all the work you've done. But as you get more confident, you might try and pivot them again. And you can say, look, there's no pivot. You're restricting your weight bearing is not going to stop a fixation of a poorly placed ACL. So really get the effusion down, go for full range of motion. They're going to restrict their weight bearing naturally for a couple of weeks. By 6 weeks, patients might still be on one stick. It's not like a hip replacement when they walk in at 6 weeks always. They're still getting through it usually. Scars are normally well healed. Depends if you've done other work. But full weight bearing, no brace routine for me. And I'd recommend that.
Excellent. Another basic science, which is about graft maturation. What is the latest evidence about the time frame for that to occur?
Yeah, that's a really good point. I just say one more point because you said basic science. I don't really say about basic science. You can look up the loads that happen in normal walking, going upstairs. They're like in the hundreds of newtons, I believe, like walking or going upstairs. So you probably should know that for the exam, and you could give a more basic science answer to the rehab. You know, there are newtons magnitudes for walking upstairs and walking along. So maturation, I think it's controversial depending on what you do, because that graft has to neovascularize and it breaks down, and it's quite scary if you have to go back into an ACL at 6 weeks, and it doesn't sometimes look like it did when you did it. It might, there are some wispy bits, but you've got the collagen framework, and some say it's about 6 weeks, I believe, that that it's weakest. The maturation, it can go on for a long time. So, you're forming ligament tensization. So that's why return to sport is a year, really, for contact sports, because there are histological studies, and you want to see those tide marks and those basic science about how ligaments join to bone. And you've got the complications I didn't really mention of tunnel widening, synovial windscreen wiper effect, of the synovial fluid being pushed up and down. So while you don't want to drill, short, smaller diameter tunnels, you really should try and get a tight fit on both sides. They've got the graft compression tubes from Arthrex to stop expansion with the fluid you put on, and that will improve your maturation. So I suppose the answer would depend on how well the tunnel fit is, the quality of the graft. But yeah, I'd say up to a year. But I haven't looked at that specific point recently.
Okay. So for acute injuries, especially with multi-ligament injuries, ACL, PCL, PLC, what would your preferred order be if you have multi-ligament injury?
Yeah, I mean,
if you get the choice, of course.
Yeah, I mean, there's a standard framework for that, and I'd urge you, guys, to look at that. It's sort of like whether you do PCL and ACL and then do the posterolateral corner, and you could come back. It depends. If you've got a medial side, you always have to do a medial side. But like major trauma, those ones, say in my practice, we do relatively high volume ACLs. And I think your question, if they say you are the specialist center, you are, guys, because they're not that many of them, and these are getting concentrated within basically in the major trauma centers, mainly in specialist centers. You might have had a knee dislocation at the time of injury. That's probably more important. What I'd want to know first, that the first answer I'd expect is, this is a serious injury. This is high energy. This patient obviously has to be assessed by ACLS protocol. That knee, which may look reduced now, may have dislocated at the time. You should know the risk of intimal tear from the popliteal artery. So you should check your pulses, do a neurovascular examination. CT angiogram is quite common. Never be a wrong answer. And doing ABPIs, doing Dopplers, make sure you haven't got that. I've seen it a few times. And I've seen those patients have multi-ligaments, been putting braces in A&E, and actually, they had an intimal tear when you've seen them, they've got sort of vascular symptoms. So stabilize the knee. It depends on your local expertise, and there I've seen variations of things. So it's difficult to give a framework about one, but I've seen you don't have to do all of them. It's quite common to do ACL and then the collaterals. You need to repair collaterals. Now it depends how bad your collaterals are. Because if you look at your guidelines for medial collateral injury and lateral collateral injury, well, the medial collateral has grades, so you should know your grades of medial collateral. If it's, a pull-off, again, from the insertion sites, that may heal with the brace. If it's mid-substance, say, of the superficial MCL, just like a knee replacement, that is a very important ligament. You might want to repair that directly and reinforce that with hamstring, and then do an ACL as well. You've got to be thinking about your graft choice. So you might use hamstring something for one, say the ACL. You might use a Lars ligament for the PCL. You might need to have that on the side. And then for the posterolateral corner and LCL, I tend to think of the Larson sort of approach, when you drill through the fibular head and just do a single screw in the lateral epicondyle. There is the Laprade approach, which is more complicated because everything by Laprade is more complicated. But again, it's not something I've dealt with for a while, but that's what I'd be thinking. Just exclude the serious knee dislocation, look at the MRI, think logically, and restore AP and collateral stability.
I think I think what you said, Mr. Punwar, about multi-ligamentous injuries coming up in the exam, it's not about your order of fixation. It's going to be about recognizing this as a high energy injury and
Yeah, I think so.
what to do. I'd suggest that if you got to the point of how you're going to go about fixing it, you're doing really well in your question, as opposed to the basic part of your pass-fail type question. And I wouldn't push to go to discussing the order of fixation in the exam because it's never going to go that way at the first first 3 minutes or so. It's all about managing the patient in terms of ATLS and recognizing that there could be neurovascular injury associated with this. I think we should leave the questions for now and go on to the MCQ portion of this presentation. If Hannah, if you don't mind putting them up, thank you. So everyone, if you could answer the questions really quickly. This is our way of gauging, first of all, how our presentation is going, but also it gives you an idea of the type of questions that can be asked as an MCQ in the exam. While you're answering the question, I'll remind everyone that OR UK is a charity that focuses on orthopedic research, but also education. Please visit their website for further courses and webinars. FRCS Mentor Group is again a charity organization. We don't get money for what we're doing, but we do raise money by doing a couple of things. First, the courses that we do, Viva courses, the money on that goes to maintaining our ability to present these talks every Wednesday. Also, we published a book, Concise Orthopedics. Please do at least browse it to see if it suits you, but we believe it's a very good book for preparing for the exam. All proceeds of that again go to maintaining this ability to provide these Wednesday sessions and maintaining the cost of the Zoom programming. The mentors give their time free, as does OR UK lecturers like Mr. Punwar. We really do appreciate that. And a reminder that OR UK also publishes quite a few books for the FRCS exam. Please do look at them as well. In terms of a middle-aged person or a younger person with an ACL injury, do you do an osteotomy or a ACL?
Okay.
Yeah, it's a classic question. They probably do it just from the medial OA point of view, and they might give you a young labourer 45 medial OA, and then if you're doing really well, you might get to the ACL rupture and things like that. So yeah, your classic young labourers with varus knees and medial OA. You can talk about hydrocerebral osteotomies because it's not going to wear out, and they can load those properly because you can't reload a arthroplasty. Now, if you're talking about then an older patient, you might want to talk about a unicompartmental knee replacement, and then they might throw that curveball in of your ACL being ruptured. And so the options are there that you can do a uni with an ACL reconstruction. Again, it's rare as hen's teeth. You'll be doing very well towards the end, unless they showed you a picture of that. It's not something I'd mention. But yeah, sort of thing, if you're in Oxford doing an exam, they might do that. The only interesting thing is, say you're doing the Oxford or a uni, they might want you to know that an ACL rupture is a contraindication to a medial or lateral, medial uni knee replacement. And they might talk about 4-bar linkage, which is quite one of my favorite questions for the FRCS from the Oxford sort of textbook. With fixed bearing unis, actually, they say you can have a bit of ACL fraying, a bit of ACL rupturing, but that again is another topic for another day, and I'm happy to talk about that at another point.
It would be brilliant to bring you back to talk about unicondylar knees. For those who want to go look this up, this is actually on our YouTube channel with arthroplasty, and one of the options we discussed was unicondylar knees as part of the arthroplasty. But we would love to have you back, Mr. Punwar, if you wish to give a talk on that topic.
I really enjoyed it.
Okay, so we'll close the polling. I'm very disappointed in you guys. Only 44 of you have answered, and that's less than 50% of the people here. But anyway, let's move on. Mr. Punwar, if you want to, please go ahead.
Yeah, I mean, I just put that one in because when I'm doing an ACL, all the maths goes out of my head usually at that point. So planning is really important because you're maybe a bit tired at that stage. It's essentially your desired graft length plus 10 for your classic endo button. So perhaps I'm showing my age, endo button, Smith & Nephew is quite commonly used. You need 10 millimeter turning space, really. I have argued this with the reps. 6 millimeters might do, but technically it's 10 millimeters will get you through. So it was C, 35 millimeters. So your drilling femoral tunnel is 40 millimeters. 25 millimeters is your desired graft insertion length. That's sort of an accepted amount of graft to put in the femur. I didn't talk about that. That's controversial, but a minimum is 15 from some people in France, and 20 is okay. So then you know you need a 15 millimeter endo button because 25 plus 15 is 40. However, you need to pull that metal button up lengthwise, clear the whole button. So you've got to pull your hamstring graft up 10 more millimeters, then 25 to 35 millimeters. Your metal button will reliably pass, flip, and you get that lovely toggle sensation. So, and it's in the Smith & Nephew Optech, which if you just look up, ACL technique, you'll find it in there with a nice picture, graft length plus 10. So the risk factor for ACL graft failure, very good. Low posterior tibial slope is not a risk factor. High tibial slope would be a risk factor. High tibial slope is beneficial for PCL injuries because your femur sits back more, but it's bad for ACLs. So people talk about slope reducing osteotomies. And, as I said, the femur and tibia was just to reinforce it's accepted to put your femoral tunnel quite far back, as far back as you dare, really, and your tibial tunnel not more than 50%. So you don't want to go less than 50%, but you don't want to go more than 50%. It'll be vertical if you do that, and you might get more notch impingement, or even talk about impingement on the PCL. The last one, well, I was clearly grasping for basic science, and you're clearly all very good at that. You need to know the properties of viscoelastic materials, hysteresis, creep, time-dependent stress-strain behavior. My favorite example is hammering in an uncemented femoral stem, because that's when you're going to get your fractures. And that might be a question they'd asked. And strain hardening, I'm sure you guys would tell me more than I would know, is to do with metals and when they pass their yield point. But it did sound quite viscoelasticy, so I thought somebody might fall for it. Clearly not. So very well done.
Brilliant. Okay, thank you, everybody. These are good questions. They will come up. I suspect some form of this type of MCQ would come up in the FRCS. Thank you very much for this brilliant talk, Mr. Punwar. The ACL controversies. ACL is a standard bread and butter operation in orthopedics. You're expected to have seen it as part of your training, and so therefore it's expected that you would be able to answer a question on ACL. The trick in these questions is talking about the controversies around it. What are the pros and cons of different ways? And as demonstrated, as long as you do an operation correctly and do it well, the patient will have good results. But I can foresee a lot of those type of questions being coached into the exam very easily, including the discussion about whether you should give VTE prophylaxis or not. I think that one is something to watch out for potentially later on. Is there, if there's no burning questions, Abdullah, we'll stop recording here and move on to our Viva session. Once again, thank you, Mr. Punwar. Really excellent talk. I know I benefited from it listening to it, and I'm very sure our people who are preparing for the exam will. If you want to go over this talk again, it will be on the YouTube FRCS Mentor YouTube channel and on the our UK website as well. Thank you, everybody.
Thank you. Thanks, John.